Hi, I'm Joseph Bavaria, and I'm here flanked on my left and right by Tom MacGillivray from Methodist Hospital and Vinod Thourani from Emory Hospital. Thank you for joining this program. So today we're going to be discussing CT surgery involvement in TAVR programs across the United States of America. And earlier today at the STS, we released and spoke about the STS TAVR manpower study, which was released to the entire United States and had approximately 471 responses out of about 500 TAVR programs in the United States. So it was a reasonably decent manpower study. So let's dive into this and have a discussion about CT surgery involvement in the United States regarding TAVR. So what do you think were some of the big take-home points today at the STS regarding the release of this information? Tom?
Well, Joe, I think the results of it are exciting, and they showed what we had hoped they would show. The cardiac surgeons are actively involved in the management of patients with aortic stenosis as part of the heart team, actually active participants in the heart team, not only in the shared decision-making, in the deployment of the valves, and in taking care of these patients post-operatively. So I thought it was a great survey.
So one of the, Vina, one of the interesting facts that I thought came out of this was that about 75% of programs in the United States are either administered by both cardiology and cardiac surgery, which you would think would be kind of the way it should be, right, or even by cardiac surgery alone, and that about 25% of programs in the United States are administered by cardiology alone. What do you think that says about CT surgeon participation in TAVR in the U.S.?
I think that's great. You know, when we started the original partner trials, the goal, partner, you know, being a joining of cardiology and cardiac surgery together, I was scared that as this went into regular use and throughout the country, that we were going to lose some of that kind of momentum that we had gained with surgery and cardiology working together. This shows me that we're doing really good, and that, you know, 3 out of 4 centers are really working together, jointly taking care of these patients preoperatively, intraoperatively, and postoperatively. I'd love to see it 100%, but I think that we're starting off good with 3 out of 4 centers doing this. Our goal should be 100% though.
So in follow-up to that, regarding, you know, the fact that at the trial level, with a lot of things,
right,
especially new technology of any type, really, culture is set at the trial level, and you know, we've got the partner trials and we have the Medtronic core valve trials. Right. And heart teams were kind of indoctrinated at that level. How do you see that has played out in the U.S. Maybe even in relationship to what's happened in Europe?
Well, I think we give a lot of credit to partner and core valve. You know, we were talking about Marty Leon, Craig Smith, and now Michael Mack and Marty for the Partner 3 study, and then you have Jeff Popma and David Adams and Mike Reardon, who you work with, Tom. I mean, the guys set the standard, I think, of working together. The executive committees were split half and half, surgery, cardiology. I think that's really where we need to go with all of our new technology. If there's a transapical technology coming up, we should have cardiology as a part of that. And I think that we've done that, quite honestly, a little bit better than maybe they did earlier than the European trials. And I think we have set the standard, which I think is admirable, quite honestly.
Right. I would certainly agree that that the adoption of TAVR, especially regarding heart teams and regarding the participation of cardiology and cardiac surgery together as two groups that work together, has been a little bit more symbiotic in the U.S. compared.
What do you think of me about that, Joe? About Europe versus here and how it's rolled out? You hope that continues, right?
Yes, I hope it continues, and I think it has been different and maybe a little bit more collegial and more positive in the United States.
Well, I think it's the mandates that came out from the government and from the societies. My view on it is that it started out as sort of an arranged marriage that has evolved into a marriage of love. I think that it really is impressive to see the cardiology team and the surgery team coming together as one big team. And they work well together, and they make decisions together, and they work together.
That's right.
So the TAVR, STS TAVR manpower study also showed that about 90% of programs have heart team meetings. What do you think about that, Tom? And also that about 82% of these heart team meetings have active participation by cardiac surgery. Do you have any comments on that finding?
Well, I think it's great to see that the cardiologists and cardiac surgeons are following the letter of the law, and I think they're doing it because of the spirit of the law. And it's, despite some people's concern that maybe the participation of surgeons would fall off, as TAVR went forward. In fact, the survey shows that's not the case, that surgeons are actively involved, continue to be actively involved in the programs.
And most of these meetings are weekly, so they're really spending a lot of time and energy, not on a monthly basis or once every 2 months, almost on a weekly basis. So I think that's something that we need to keep up and try to encourage.
Right. I think the TAVR survey, I can't remember the exact numbers, but it was approximately 70% of them were weekly, and another 20% were bi-weekly, and a minority were monthly or longer. So
those are probably newer programs, I would guess, that are starting to ramp up, and they don't have the patients to meet weekly. Maybe that's why they're doing that.
Yeah. Or maybe they don't have enough patients.
Right.
And that's true. There was about a quarter of the surgeons surveyed had fairly lower volumes, like 1 to 4 TAVRs per month, which you would expect looking at the TVT database.
Exactly
showing, Yeah, you want to comment on that a little bit?
Yeah, I mean, the majority of the programs are still doing under 50 cases a year. And so if you divide that out, that's 1 a week. And so I think, that makes sense to me that some people would have it bi-weekly. I think that as our volume increases, and you and I have seen some of the data coming out recently from TVT Registry, the number of patients that are going to get transcatheter valve may crisscross with the number of patients getting surgical valves in 2017. Right. So it almost becomes an equal number that are getting TAVR and SAVR in 2017.
Right. We could expand a little bit on that. It seems like that most of that, and it will cross over, that we'll see more TAVR than SAVR in the next year or two. However, it seems like the SAVR volume itself is, while not going up, is actually not going down that much.
So at our institution, what we found was that, as in many other institutions that do TAVR, that the total number of aortic valve procedures continues to go up. And as TAVR volume, of course, is going up, but our SAVR volume is still pretty robust.
Yeah, so the data that we looked at from TVT and STS, you're exactly right. Through 2015, there hasn't been a very appreciable decrease in the number of SAVR patients. The incline, the total population has gone up, all driven from TAVR. But you're right about that, Joe, and I think a lot of those patients are low-risk patients, and it'll be interesting, and I hope they continue to do those patients in large numbers in SAVRs.
Well, we'll have to see what the the low-risk trials show. Yeah. The low-risk trials will probably be out in 3 years or so we'll have to see how that goes.
But don't you think, one of the things I found remarkable was that a lot more patients who would benefit from aortic valve intervention are getting them. Right. And I think that patients who wouldn't have been referred to a cardiac surgeon or a cardiologist even are now being referred for this really life-saving, life-quality improving therapy.
Absolutely. I think this points to the power, especially from a clinical standpoint and patient care standpoint, of the heart team working together. And our survey, the STS survey, would suggest that the heart team, while not perfect, is pretty well and alive.
But I tell you, Tom, I want to comment on that a little bit. It's a testament to randomized trials. So in the last 6 to 7 years, we've put in about 7,000 patients into randomized trials for the management of aortic stenosis and partner and core valve trials. That's a lot of patients. And for the first time, surgery cardiology coming together to do good randomized trials in valve patients, I think this sets the bar for future technology coming in. Randomized trials really drive therapy change. For whatever it is, it's overall therapy change.
Yeah, and it's also they were done together.
Right.
They were all done in it together. So let's talk a little bit about, instead of, let's take the TAVR experience, so to speak, by the patient and chop it up a little bit into preoperative, intraoperative, and postoperative care. So it was interesting to me that our STS TAVR survey in the United States showed that about 90% of patients, 80 to 90% of patients, are either referred through cardiac surgery or referred through both. What's your take on that number?
I think that's great, and I think that the patients coming in to who they traditionally have the management of aortic stenosis, which is the cardiac surgeon, and I think that as that cardiac surgeon gets more and more equipoised on what to do with these patients and calculating STS proms, they're going to take them to the heart team, and they're going to make a team decision together. So I'm proud to see that the cardiac surgeons are bringing these patients in, along with their cardiology colleagues, into the heart team and really disease management instead of just one therapy or the other therapy.
So do you think that that's a result of kind of a slow progressive maturation of the valve heart team in TAVR centers?
I think in part, Joe, I think that cardiac surgeons have historically been recognized as the doctors who take care of patients with severe aortic stenosis. And I think that that has been true and it continues to be true. We understand how to manage these patients in the peri-procedural time period, and it's nice to see that we're still doing that. And I think that having more people involved is better than having fewer people involved.
So I think I was a little bit surprised by that statistic, and I was pleased to see that the vast majority of patients were seen in some sort of combination between the cardiologists and cardiac surgeons.
Surprised? Why were you surprised?
I thought it would be maybe one or the other, but not as much as a team effort, to be honest with you. But those were nice data. That's a pleasant surprise. Yeah. So what about this? So the STS manpower study for TAVR in the United States also looked at the conduct of the operation. In other words, taking it from the very beginning with access and then to the placement of the valve inside the aorta and into the valve annulus, as well as deployment and positioning of the valve to closure and taking care of access issues. So it was interesting to me that every one of those conduct of operation time points, and there was about 10 of them, including getting through the valve with the wire, as well as positioning and deployment of the valve, were above 50% of all surgeons. The only category that was less than 50% was actually operating the endovascular table, which was at 36%. So what do you...
I found that funny, quite honestly, yeah.
So what do you think about that data? Obviously, access both before and after was majority cardiac surgery, but what do you think about the conduct of operation statistics?
Well, I think that data debunks the urban legend that surgeons aren't doing the procedures. I think it shows that most cardiac surgeons are actively involved in every aspect of taking care of these patients, including deploying the valve.
Yeah, I was happy to see that too, because like you, Tom, I thought that there were some not interested, and I was very happy to see this type of results. I would tell you that the first thing that I do before the resident touches the patient for the first couple of weeks is say, learn how to use the table. So hopefully it was none of the guys that I trained who said they didn't know how to use the table.
Right. The 34% was.
Yeah.
So yes, that's interesting. Let's talk a little bit about postoperative care. So the TAVR survey also examined, how these patients are taken care of after the procedure, and it was interesting to me that again, approximately 75 to 80% of all TAVR patients are either taken care of by the cardiac surgeon on the cardiac surgical service or by a mixed cardiology cardiac surgery service. Actually, there were more patients taken care of on a cardiac service than there were on a cardiology service. However, most patients were taken care of on a mixed service. What do you think about that, Tom?
Well, I think it just makes sense. I mean, cardiac surgery is the quintessential medical team sport. We have multidisciplinary teams to take care of patients for all kinds of cardiac problems, and that the natural place for patients to go is to a cardiac surgery team that's set up to manage patients with all kinds of comorbidities and other problems.
I was worried about that it would just go, especially now since we know that from TVT registry that roughly 90 to 95% of patients are being done transfemoral, that would be an abandonment from the cardiac surgeons. But I think that is very important for us to see the patients post-op, be a part of their care, to listen to their hearts, look at the echoes the next day when they've had that, to evaluate the TAVR valve being done. So I think it's good. I encourage people to stay with it and don't abandon it.
Yes, I have to be honest, I was very pleased. And again, it's the same kind of concept as we've been talking about for a while, that the heart team is not just alive and well at the preoperative and intraoperative phases, but even at the postoperative phases, where most patients are taken care of by a combination of the two services, and actually a significant minority of patients are taken care of on the cardiac surgery service alone. So the TVT database went into some data. If you look at the data from 2015 into 2016, through March 31st, 2016, that about 9% or so of patients are about, let's put it another way, 91% of patients are done in a hybrid operating room of some sort, whether it's a hybrid cath lab or a hybrid OR, but those kind of words don't mean a whole lot. And that number has actually been increasing. Is there we were a little bit surprised about that, but what do you think about that?
My personal view on that is what really matters is what's done, not where it's done. And
I
I
would
think
definitely agree with that.
Right, absolutely. So I think either place, I agree with Tom that either place is fine. I think you have to have the right team, the right steps. I think if it's done in a hybrid cath lab, you have to still run through your checklist, make sure that all the safety protocols are there, that if you need a bailout, that's available immediately to you. So I think the group and the heart team, by looking at their quality and their TVT and analyzing their data over and over again, I think it's critically important to make sure that they're doing it as safe as possible with the best quality that they can. And if there's any deviation from that, I think the whole team needs to reappropriate what they're doing.
So we take this data from the TAVR manpower study, which shows a significant participation in this arena by cardiac surgeons, which we would expect because of the NCD and because of the culture of the two teams working together. Where do you see this going and taking it further than TAVR, like in transcatheter mitrals and other structural areas that may be a little bit more complicated? Any idea?
Well, I think the paradigm that has been set up for aortic valve disease is a great one. I think that we have proven proof of principle that the team concept works and it works well. And I think we should extend that into other aspects of structural heart disease.
Well, I tell you what's happened with us is that the heart team has expanded even more. And so we've gone from an interventional cardiologist and a cardiac surgeon to now a heart failure specialist. So we're doing a couple of early feasibility trials in mitral and tricuspid. Now we've made sure that an imager is a part of our heart team. We've made sure that a heart failure specialist is part of the heart team, because some of these patients can just be managed with guideline medical therapy, directed therapy, and we need to make sure that surgeons who aren't as familiar with some of that and interventional cardiologists who aren't as familiar with that really get proper education. So we've actually expanded it, and it's a better team now looking at some of this newer mitral and tricuspid technology.
Well, I think that's certainly true in mitral and tricuspid
Absolutely.
technology, because
Right.
guideline-directed medical therapy is a significant part of that.
That's right.
It's in TAVR or aortic valve surgery in general for aortic stenosis, replacement of the aortic valve for symptomatic AS is a Class 1A indication for treatment.
It's a no-brainer.
It's a no-brainer,
Right.
but this is a little bit more complicated when
That's
you get
right.
to
So that's where I think that's expanded into some of these new technologies coming out.
Well, I want to touch on something that Vinod said, that I think it's incredible, the advancement and the imaging that has taken place, and image fusion and the ability to really have experts with us on the heart team who can help us see and use the imaging to its biggest potential.
Not just echo, we're talking about CT and MRI.
CT,
Yeah.
absolutely.
Yeah.
So just real quickly about some of the methods of the STS manpower TAVR survey in the United States. We know at the time of this survey that there were about 450 TAVR programs in the TVT registry, and there were 310 TAVR surgeons who responded, who were actually doing TAVR. So this is a significant significant representation within the TAVR surgical community. Any comments on that? Do you think these data are real enough to take to the bank?
I think that they're significant statistically, and I think they're remarkable. Getting people to respond to those kinds of surveys oftentimes are difficult, and the return is low, and the conclusions you can draw are limited. But I think the return we got on this is really remarkable, and I think it's great data.
I think that from the professionals, the response for this manpower survey was about twice as much as a normal survey.
And the stuff that we don't have time to talk about are the comments, right? I mean, the comments, there's so many comments which are very enlightening to read through, and which, again, we don't have the time today to go through that, really shows the interest of people typing out stuff instead of just clicking boxes. And I think that just shows you how interested this whole field is to cardiac surgeons.
No question.
Well, Vinod, And Tom, thank you very much for joining me in this panel discussion on the state of TAVR, especially regarding cardiac surgeons in the United States, but also about the entire heart team regarding interventional cardiology and cardiac surgery together. Thank you very much.
Thank you, Joe.
Thanks, Joe.